Good morning, everybody. Welcome back. Welcome to the final day of the fourth annual SPORE Summer Institute. Hope you've enjoyed witnessing the impact of patient-oriented research in Alberta. My name is Ross Tsuyuki. I'm a platform lead for consultation and research services with AB SPORE U and a professor in the Faculty of Medicine at the University of Alberta. Let us start by acknowledging that we're on Treaty 6 territory and we respect the histories, languages, and cultures of the First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I hope that you've all had a chance to enjoy the discussion from last night's talk with Sick Boy podcast, and if you missed it or wanted to learn some more, they are running another workshop here in this room after this panel discussion. There'll also be 3 other workshops happening at the same time after this session, which includes should we measure the impact of patient-oriented research, or is it just the right thing to do, with invited guest from PCORI, Dr. Rachel Hemphill. It's now my pleasure to introduce you to our panel this morning. Jerry Jackknife and Keith Miller are peer support outreach workers with the Edmonton As It Is chapter of AWARE, the Alberta Addicts Who Educate and Advocate Responsibly. AWARE is a provincial network that meets to build capacity within the community of people who use drugs. They meet to build capacity and ensure that those of us with lived and living experience are at the tables when decisions are made that affect our community. Both Keith and Jerry are also members of the community advisory group that's attached to the ARCH team. Both are long-standing members of AWARE due to their extensive knowledge. Dr. Ginetta Salvalaggio, sorry. I practiced that at home, yeah. And we had met before, too, so is an associate professor with the University of Alberta in the Department of Family Medicine and associate scientific director for the Inner City Health and Wellness Program. She received her degree in medicine from the University of Alberta and completed a family practice residency in Thunder Bay, Ontario. Initially practicing as a rural locum, she eventually returned to Edmonton to establish a maternity care and family practice. She joined the Department of Family Medicine in 2007. She's also completed a Master's of Science in Population Health through the University of Alberta School of Public Health. And her academic interests are focused on social accountability, patient and community engagement, and health services for urban underserved populations. There has been a slight change in the program in that we have regrets from Dr. Dong, and her presentation will be done by Dr. Salvalaggio. So without further ado, please join me in welcoming Jerry, Keith, and Ginetta.
And thank you very much, Ross. And Catherine does set her regrets. She had an unforeseen circumstance that declared itself very late last night. So we do apologize, both of us, and I will do my utmost best to represent a phenomenal woman. I've been with the Inner City Health and Wellness Program from the ground floor, and I am a clinician, but I'm not the clinical director, the program director of the program. So I'll do my best to represent what we've done together. And I was here initially to represent the research aspects of it, but I think I can speak to both. Honestly, the main event today, folks, is these two. So I hope I'll just kind of pave the way for them to tell their stories and share their stories about impact. So without further ado, I'm going to just speak to what Catherine wanted to speak to first. We have been working on improved health services for urban and underserved populations around here, sometimes referred to as inner city populations, for some time now. We've been recognizing, both of us, along with many of our colleagues, that we've got a lot of system cracks. Perhaps I'll quote Leonard Cohen now. I don't know how many of you know this quote about when you've got, now I'm going to have, now I'm going to lose the quote I was going to tell you, but when you've got the cracks, that's where the light comes in, right? You guys remember that song? All right. So that we wanted to shed some light on those cracks and try to mend some of them and try to heal some of them in the system. And so we have done a lot with respect to asking people with lived experience, what do we do to mend those cracks? What do we do to fix them and to improve health services within our setting, both in the community where I'm situated, as well as in acute care where Catherine is situated, and as well as the transitions in between. So we have involved the community in planning the program right from the beginning, many moons ago, over a decade ago. We had a community planning day times 2, 3, 4 iterations. We evoked a community advisory group. We got input. We treated these folks as equal stakeholders, oversight level guidance to our program development. And we developed the Inner-City Health and Wellness Program with their meaningful involvement from day one. We have a clinical arm known as the Addiction Recovery and Community Health Team, or the ARCH team. That is Catherine's purview, in addition to oversight of the whole program. I lead the research arm along with Elaine Hishka, and we also have a educational arm too that goes to bat doing roving educational rounds unit by unit at the Royal Alex, leads Inner City Health and Wellness Program symposia, and so on and so forth. So what is the purpose of the ARCH team? We want to seize the opportunity to use a healthcare encounter as an opportunity to engage and build a relationship. So our early research in the Emerge with patients made us aware of how time at the hospital is an opportunity for change, okay? Not just around that acute medical condition. We want to get away from a crisis orientation, but moving more into, you know, what other wraparound supports do you need to be well at this point in time? And many, many people in the emergency department in our initial needs assessment told us this is an opportunity for us to deal with a lot of the social stabilization issues that we need, a lot of the addiction stabilization issues that, should we need them at that point in time, we would like to access, which is not the case for everyone, incidentally. So we have some guiding principles within our program. We take direction from the needs of the community that we serve. We don't just rely on other stakeholder input. We rely first and foremost on their input. All activities are driven with the philosophy of reducing harm. So we believe in a full spectrum of care for people no matter where they are at and no matter what their needs are. We will accept people no matter what they wish to do going forward with their A, health condition, or B, their decisions about what else they consume, or so on. Just like we would respect any one of you if you decide to smoke or if you decide to have a pop today, we're going to respect everybody. The team and its activities will be culturally competent, culturally aware, and we'll focus on relationship building. I think relationship is first and foremost in our mind, and you'll see that in our ARCH team implementation manual if you Google that on our website. A broad definition of health. Okay, so we're not just talking about physical health, but we're thinking about mental wellness and so on as well. And we expect that all of our activities are action-oriented and widely accessible. So we have developed just some basic, we want to make sure our approach is evidence-informed and standardized and not off the cuff. So we've done a lot of work to make sure that we provide the highest quality care possible, and we've evaluated it along the way, and we have a quality council and quality improvement stuff. And when something's broken and we need to troubleshoot, we call on these guys as well. Hey, look, we've come across a need to address people who are using washrooms around the Royal Alex Hospital to use, and we want to make sure they stay safe, and we can't monitor all the washrooms. So how do we deal with that? That was just a recent thing that came up, okay, as an example. We have built partnerships with other, rather than stay siloed within health, we've built partnerships with police services for people who wish to deal with outstanding warrants. Again, people who wish that. We have had a homeless translation coordinator working with us to make sure that people who are dealing with homelessness can also access income support, because sometimes when things are too siloed, you can't get everything to line up in a way that allows you to access a home. So we've done a lot of those things because all of those social determinants are so important to health. And all of that came at the suggestion of the community. And then addiction management is a large part of what we do. We do opioid agonist treatment starts. We do a ton of counseling, motivational interviewing. We have an outreach worker come and sit with people and navigate the system. And that's someone who's a peer support worker as opposed to someone who does not have lived experience. We look for concurrent disorders such as pain, mental health, and so on. So it is quite far-reaching. And then we try our best to connect people back to community-based care in a meaningful way, and we do that in as warm a handoff as possible. So we've done a lot of QI work, for example, with Boyle Macaulay Health Center, another one of our partners, where we try to figure out, can we actually connect people where they feel like there's a seamless relationship and everyone's talking to each other. So we've looked at pre-discharge visits together and things like that. And then that's just a few of our partnerships over and above the ones that we have right here with the AWARE group. So we don't do this work in a silo at all. These are just some examples of some quotes of some people, some patients who told us what they think about a variety of harm reduction proposed initiatives within the hospital. And so we do it using rigorous research. A lot of our research is qualitative, not all. We do a lot of quantity as well. But Catherine wanted to highlight these quotes because they were really meaningful to her and allowed her to plan appropriate services. So we are all co-located. I failed to mention that. The research arm is across the hall from the clinical arm. And we connect, and the research is taken up real time. So it doesn't sit on a dusty shelf ever. So she just wanted to highlight this one around what is the value of having needle exchange in the hospital. And this is another one. This is how, forget about formal planning for spread and scale. All you have to do is do a decent job, and word spreads. Word of mouth spreads very fast in the community. But having said that, word of mouth of negative experiences spreads very fast as well. So you just have to be very mindful of that. Okay? And then more recently, last year, we actually celebrated our first year anniversary. We implemented the first supervised consumption service in an acute care facility in North America. And we did some pre-work, and we've done some post-work about what the, well, we're still in the middle of the post-work, about what the experiences have been of both patients and staff. Okay. So this was just a way for people to feel a little more safe, for reducing the harm associated with a hospital visit for people who were still actively using drugs. So those are the ones that she wanted to highlight. And once again, thank you for putting up with me, because I probably can't do her content the same justice that she would do for herself. But so my perspective as a researcher, this is classic stuff. I use two metaphors that colleagues of Jerry and, I nearly called you Jeff, Jerry and Keith's colleague Les gave me these two metaphors a long time ago. One of the tangled fishing wire, and one of Alice in Wonderland going down and down and down and never finding a door that fits. And that's what it's like to be a patient in the health system. So I always use these metaphors now when I speak. We need to think about whether our patients are being served by the health services planning and design that we do, but also the research. So traditionally excluded patients are, of course, going to be underrepresented in data. They're going to be excluded from all the RCTs because of complexity. They are real people, but they don't show up in our data, our traditional data. So just think about that for a minute. And you have to be equitable in how you sample and how you recruit. And then so as a result, we inappropriately extrapolate results and plan and design and scale interventions based on somebody else's profile, patient profile, health profile. So that's not right either. We don't do meaningful knowledge translation that involves people with lived experience. We don't engage them at the beginning, traditionally. And then we also tend to plunk in pilot interventions that we then pull away. And now think about that from a trauma-informed perspective. It's not just about trauma-informed care, it's about trauma-informed scholarship. So think about the impact of going in and flying in, and those of you who've done work with Indigenous populations, think about just going in and doing whatever research or pilot you're going to do and then taking it away. And what that does, that loss, that perceived abandonment. So you have to have some kind of a downstream plan. So we adopt a nothing about us without us approach, and I did not invent this term or coin this term. The first instance I've seen of it was within the HIV/AIDS community, and a lot of work has been done about that, but this is not a new concept. Action orientation is critical. We need to have patient-centered outcomes, and we need to act on them. We implement services in a co-design process with frontline as well as with patient stakeholders. And we don't rely on administrative data alone. We cannot just use big data and mine big data alone. We also need patient voice, which is why we actually really embrace and value qual and mixed methods in our research. I should mention, though, we also do administer quantitative patient surveys as well. So there are different ways to get patient voice as well. So these are a couple of seminal documents that have certainly guided my work and Catherine's work and Elaine's work over the years. One is an HIV/AIDS legal network document. You can find both of these online, entitled Nothing About Us Without Us, Meaningful Involvement of People Who Use Drugs. Purology was written, it's a guide by and for people who use drugs on how to get involved. So it's a patient engagement guide for people who use drugs, but I tell you, it's very meaningful to me as well, and I've learned a lot about best practices. So I encourage you, when you're thinking about people who've been traditionally excluded, to think about these things. They go through things like, what can I expect as far as remuneration, as far as where people will meet with me, as far as how often they will meet with me, as far as how many of us are going to be involved. So how are patients involved? We have 2 community liaisons. These lovely ladies are there presenting at an international conference with me. And they help share information about what's going on in the community, and we share back. They coordinate our community advisory group. They've helped us from a research perspective with recruitment, with retention. So we expect about a 50% attrition rate in a big quantitative sample because of life experience, but it would be tremendously lower, let me tell you, if I didn't have somebody from the community able to find people on the basis of a 3-page contact information sheet that we have people fill in when we start. So they've been very, very invaluable in making sure our research is as rigorous and high quality as it can be in a community-based setting. They help with data collection in a pinch, so we'll sometimes have people who we've tried multiple times to get connected to our research assistants, and for whatever reason they feel more comfortable talking to a community liaison. So we have trained people in data collection as well. They certainly get involved in the analysis side, but usually that's as a group. So turning things over to the community advisory group for a moment, they assist with staff hiring and training. We get people to do a little bit of field-based orientation. If they are planning to be collecting any data with patients whatsoever, we want them to spend some time in the community understanding where people live, not just the hospital setting, right? They help us with program design and troubleshooting, as I alluded to earlier in Catherine's slide deck. We get them involved with methods about what might be the best way to approach this problem, what might be the best way to ask. They help us pilot our interview guides. They help us practice them so that we don't inadvertently create more trauma, or we don't end up asking a question that's really confusing for someone who doesn't have a university degree. So it really helps us to practice and troubleshoot together. They help us interpret our data, and they definitely help with KT. That is something that I can tell you really, really, from an impact perspective, really helps people feel like they're giving back to their community. Okay, they help us understand evolving contexts. We started many moons ago now, a study protocol, started out looking at complex high needs populations as defined by a health system, but realized that we had to change aspects of our outcome measures along the way because of evolving things going on, such as an opioid crisis and so on. So just being able to refine our protocols over time with good, solid justification along the way. So it has helped us tremendously. So we talked about KT, thinking about what the message is and whose message is it. Who is the messenger? Who is the audience? Just an example, one of our community advisory group members sitting with one of our former research assistants. They are co-messaging something to physicians together. So we talk a lot in KT world about it being the researchers conveying the information to the masses, and we believe that it sometimes has to be flipped, and sometimes it's the patient voice that needs to be the one messaging to, say, clinicians or policymakers. So we involve them in as many of our presentations as we can, as many of our publications as we can, and we ensure that the language is something that doesn't reflect my perspective, but theirs. This is I just wanted to share a booklet that they put together, a poverty intervention resource by and for people with lived experience of low income. Just some snippets of the book. It was meant to not be fussy. It's meant to be something that's practical and something that isn't too glossy. So tons and tons of resources in there, and at the end of the day, and this is the reason I wanted to put up this slide, is we had a big celebration, and the celebration involved laughter and it involved food, and it involves recognizing that we have strengths, that it's a strengths-based process when we do research and we do KT together. So I do strongly feel as a clinician that the scholarship we do can be harmful or it can heal. So we can either build capacity within a community, we can help people work on their resumes, we can help organizations who partner with us to sustain their funding for their own operations over time. We can partner, we can remunerate properly, we can ensure people are recognized and acknowledged where it is due, or we can harm. So it's a choice that we can all make. And there's Jerry, along with Les, who photobombed us one day when we were taking a group picture at the hospital, and we were so excited because it's a better picture with them in it. So I'm going to turn it over now to Keith and Jerry to tell whatever stories they want. I will put up one slide that their colleague Chanel, who is not here today, just some points about what patients want when they engage in research. So I'll leave it there for your digestion while you listen to their stories.
Good morning, everybody. Thanks for being here. Thanks for asking me to be here. I guess I'll start off with where I'm from. I'm from Hartford, Connecticut, and I moved up here in '66 with my father, who was just becoming a biologist for caribou. Well, he was a biologist for white-tailed deer, but he became a biologist for caribou up here. And then we moved across from Ottawa to here to Edmonton, where I pretty well got my years of being a partier around here. I found Edmonton was really good at that. And yeah, started my use of codeine probably 25 through to 35. and then slowly progressed into morphine and eventually into heroin. And then I did get some help from certain doctors, but it was a really hard thing to do until, excuse me, until recently, you know, probably the past 10 years, we became a lot more open about things and a little brighter about things, that everybody has value. And the Arch really showed me that. It was like the Ark of the Covenant. Other things are, I gotta shake this out. Anyways, yeah, it was pretty tough back when there wasn't any help. That's what I can really remember. You know, when there was, you had to make it work. You know, you had to make whatever you had work. You know, you get sick for days on end, and you couldn't hold a job because of that. Couldn't hold place in society, and people started just, you know, disown you. But coming involved with the Aware, and as it is chapter, Chanel is a really powerful person that runs that. And Marlis is a good friend too, but Chanel has something, a firefighter, I think, is going to go a long ways to help everybody in this country. Sometimes I feel a little emotional about the whole thing, but it is a powerful tool when you start collaborating with people, you know, from every corner, finding out the story is the same and the trouble is the same. Oh, I'm tired. Anyways, you know, like, there's other people, well, there's other people besides Ginetta that I met, like Robert. He was an unbelievable person too, that's inside the system, willing to help everybody. Like, there's a lot of people out there that really have a big heart. But, you know, in my time, having a big heart meant being a big victim. Because a lot of people just take advantage of that. So, you know, it can be a really rough ride. So being a people pleaser or a helper is not a very good occupation, because there's a lot of hurt in there. Because people are people, I mean, of the flesh, I guess, and we always consider doing something wrong before we do something right sometimes. But why, I don't know. I think our society has to improve, and this is one improvement. The Arch is going to, I don't know, hopefully break some barriers, especially with people on the street, minorities, and, you know, people that just can't get in the system and are falling through the cracks. And, you know, I believe one day, especially Alberta, are going to be that much farther ahead. You know, it's a beautiful thing when you're part of it too. It gives you empowerment every day. If there's anything else you people want to hear? Yeah, okay. Well, thank you all for listening, and have a beautiful day.
Good morning, everybody. My name is Jerry. I've been Aware member for, well, pretty well since the beginning. That's been about 14 years ago. And let's see, I'm an addict. I've been an addict since 1967, still doing it. And I like to give back to the community, so I joined this group of Aware and started doing a lot of good back to the community, see how they did and where they were going, and that's where the way I wanted to go. So I started with them, and ever since then, it's been good. Like, it's, how do you say, an experience. Like, you meet different walks of life, and they're all different. Like, so I got to get to know everybody a little bit better now, and it opened my eyes quite a bit. Like, you see a lot of things going down in the city. A lot of people don't care about addicts and that. And, you know, it's not right. You know, addicts are people too, right? And that's what I find, and that's what I like to do. I'm kind of shy to be standing up here too. So now I'm lost. That's what I like to say. I'm sorry.
Okay, well, thank you very much, everyone, for your presentations. So we're going to move on to the next part, which is a panel discussion. Thanks so much for sharing your experience, but also your service and your courage. I have a couple of questions to maybe get you started, and then we'll go for questions from the floor. But I guess the first thing is, this is a conference about patient engagement, and so can you tell us what impact patient engagement has had on you personally?
What impact has it had on your work with us?
Working with Arch is a very good thing. They've opened our eyes and we've opened their eyes, and together we do wonderful things, like for people that are less fortunate, right?
So, and as you said, you like to give back to the community, so you've found that that getting involved has been helpful.
Yeah,
Please go ahead.
Yeah, it's on now. Testing. Okay. First, the Arch, being a patient, what was the question again?
How does our relationship help?
Oh, the relationship has been probably one of the best, like I probably said in my little statement there. You know, it just brings, every time we deal with people, professional people especially, when they come down to our level and ask us about something, it empowers us. So, I mean, it makes us feel great. You know, we actually feel like a contributing citizen.
Thank you.
I'll speak to it from
Please.
both a clinician and a researcher. I think it's made me a better clinician because I think it's honed my own relationship-centered care practices, which is a central tenet of what we should be doing in medicine and nursing and social work and so on. So I think it's just helped me be a more relational person. But I think from a research perspective, it's much more powerful. I mean, I think I alluded to some of the impact things. I mean, we've had an opportunity to have impact beyond scientific publications and presentations in a way that warms the cockles of my heart, because it's actually, there's uptake by policy. I mean, these guys are getting consulted now to you know, develop patient engagement strategies for at the province level, at the national level, because we've given them a safe space in which to have a voice. So.
Thanks. And so as you point out, and you pointed out in your presentation, it's about the relationship and developing the relationship. So can I also ask any advice that you'd have to others who are trying to work in this area? You know, if you were just getting started, what would be your advice?
Thanks. Anyway, my advice would be just, you know, find a group that you feel like you can contribute to, and, you know, it's always going to take a little bit more to get in maybe, but you got to try just about all the little angles, because you never know what group you're gonna find comfort in, or, you know, or empowerment again, that's gonna work for you. And it's usually just by, like even right now, stepping out of character, you know, out of my comfort zone and trying to achieve something. But that's about it.
Yeah, you'd have to have patience, compassion, a lot of things. Like, people don't understand us addicts very much, so like, you got to get to kind of know them to understand them, right? And when you get to start to understand them, then you'll have great success.
So from a research perspective, this takes time. It takes a lot of time. Build that into your plan, build that into your budget. It takes money. That's only fair. So think that through when you're devising your critical path and your Gantt chart. But in addition to that, I mean, recognize that the best patient engagement, in my view, goes beyond a specific project, but it's more programmatic. It's you're in it for the long game. And consider that as well. What's in it for you, but what's in it for the community, and what would they like to see? Sometimes people only want to engage for a short while. I get that. These guys are in it for the long haul, so I need to honor that. And the other thing is that this all happens on a continuum. What we're doing now, 15 years in, would not have been possible without some baby steps. And we were doing much smaller baby steps in the early days in developing a relationship. The relationship was helped because we worked with an existing group of people who already were interested in advocacy within their community, so that helped a lot. And my only other advice at this point for you all would be to, if you haven't done this work, or you're struggling with it, or have encountered pitfalls, is to try to find a mentor for patient engagement work as well.
Great. Well, thank you. And have you found that the research funders, you know, the people who put up the money for this, do they understand this? Do they you know, for anyone that was trained in a sort of a traditional research kind of discipline, you know, you're on cycles of 1 or 2 or 3, maybe 4 or 5 years, you know, which are really short cycles, and they want to see results right away. Do you find that there's an improving understanding of that from the research funders?
I personally think that patient engagement has become such a normative behavior now that funders have accepted it and acknowledged it, and as long as you build these sorts of things into your path with that in mind, it's viewed upon favorably. Sometimes it's worth thinking about it as far as building that into your KT strategy and talking about how patients are involved with that as well. And I think funders tend to, if you've got a robust KT plan, it's also viewed favorably. So there's different ways to build it into a grant for sure. We, and I didn't speak to this, it's on the next slide. We've benefited from, there's one more slide just as acknowledging some of our main funders. And I would say that we could not have gotten to this level of playing field without some in-kind supports, such as Streetworks, who's seconded a lot of the community liaisons' time, for example. So community partners, people who invested in us that way, but also a hospital foundation, people who you typically wouldn't expect to help provide you with bridge funding to get you going, such that you can then attract and leverage the more traditional research funding from there. So you have to find your pockets of money somewhere to get started and also to bridge. So.
Okay, thank you. Well, that's good news, I think, for the field. I think what we'll do now is take questions from the floor. There's some microphones around. If you can put up your hand and we'll deliver you a microphone. Yes, over here.
Okay, seems like I'm first. Thank you very, very much for coming and being brave and sharing your stories with us, and thank you for doing what you're doing and all the people behind all those names up there. I was just wondering how you deal with youth, that is, kids who aren't of legal age, and what you're obligated to do, in that, because it seems like you can really work with the adults, but are there barriers to providing similar supports and services for 18 and under? So I'd love to hear.
I'll let you speak to your experience in the community in a second, but I would say our context is quite unique. We typically, because of the hospital that this is based at, we typically don't see a lot of true youth. We have a few young adults that we tend to see, but they tend to be across the river over on White Ave and at the Stollery and so on. And so we haven't had a lot of that in our specific health services research and programming. It's not to say it doesn't exist. Certainly, you guys have had some experience with, there's the youth unit and so on. So I don't know if you want to speak to some of that.
Well, there's of course, there's the youth unit and all that, but it's still, it's going to still be a big problem because kids are kids, and I mean, they always weasel through the cracks, and they don't want help because they know it all. And, I got kids, I got grandkids, but I mean, it doesn't ever change. I mean, we all have a little ego when it comes to getting help. But that is a really big area that I wouldn't really want to touch myself because it's very turbulent, very unpredictable. But there is getting to be more and more help. And there, besides the government, there's starting to be private outfits, like always, excuse me, there's always Catholic help or health, or whatever they call it themselves, Catholic school health, something like that. And they do their part, but then there's the rival between the church and indigenous people, of course. That is going to take, it won't be a patch out there ever, but we got to come to some civil understanding, but that's about all I have to say.
Thank you.
Well, see, we do outreach in our group like every week, and we go out in the streets and help people. We've never come across any kids or youth doing it, right? So we don't really know what to do if we did come up to them. Like, do we help them or not, right? Because we could have legal consequences against us, right? So we haven't even discussed this part yet.
Okay, thank you.
So there's definitely a need there. We haven't, there is a lot of needs, and we haven't scraped the surface of that one for sure.
Thanks, great question. Yes, over here.
Hey, thank you very much. Lisa Ridgway here from the BC Support Unit. If you could speak directly to the politicians who are against safe injection sites, if you could spend 5 minutes in a room with them and shake their cage and rattle their bones, no physical harm, what would you say to them who are against safe injection sites?
Oh dear. You guys go first.
Whew.
For the ones that we do have now, I think we should tell them, well, look at the numbers. How many people died in these safe injection sites? None. How about in the streets? Lots.
Well, I would have to ask them, what's the problem to start with, because, it's definitely doing a positive thing. I mean, politics and positive things don't mix, but, I don't know. Really, what do you do with a politician? Like you could annihilate them, but there's another one would come in. But, I mean, you got to outthink them, I guess. Maybe that's a strategy to start thinking about.
Okay, it really depends on the politicians, but you specified a politician who has a negative stance. Okay. It's about healthy families, healthy communities. It's about the social determinants of health. It's about getting people back to recovery and function, because we have that evidence. We don't have to create more evidence. We know that people, it's an opportunity for stabilization for people who are ready for that or want that, and for people who don't, well, we're keeping them alive.
Thank you. Yes. And I think there was another question here. Or, sorry, did you have a comment?
Just to that, yeah, just wanted to know if the community, does the community trust the establishment of safe injection sites?
I don't use safe consumption sites, but that's a good question, because it's, when you do a drug, sometimes it's an environmental thing. So if you're using the washroom at Walmart, you'll use it no matter even if it's consumption sites all the way around, because it's just an environmental thing. Yeah, it has some really funny ramifications because of it. But I don't know if that answers your question, but that's all I can really say on that.
Yeah, the community, a lot of community members support it, and then some don't. Like, it's just a 50-50 thing, right? It's either you like it or you don't, and a lot of people don't like it.
So we're in the process of unpacking that right now. We do have a grant looking at our post-implementation experience with the SCS in a hospital setting, which is a unique setting. So I'm speaking to that hospital setting when I answer the question about do people trust it or no. So we are going to do a mixed methods evaluation. We're going to be looking at, of people who were offered or attended the SCS compared to people who were eligible but didn't attend. How do they differ? We're going to be speaking to patient and staff experiences with it in the early days about what were some of the positives and what were some of the barriers, and just unpacking that a little bit so that we can, again, feed it back to our clinical team to, from a QI perspective, to refine the model, okay? But it has taken a lot of, the education arm has had to go to bat. It's taken just unit by unit, telling people, assuaging any concerns, just talking to people about why it is we're doing that. That's been co-messaged by people with lived experience, and we also have tremendous leadership at our hospital. They are also fantastic champions, and they said this is our policy, and we're going forward. So
I was going to add, something we haven't talked about is mental health. I mean, that's really the source of the reason of addiction. So since we moved on to that, I think we're going in the right direction. But you don't know what a person's mental health is, or don't know any of the background. That might put a swing on things as far as where they go.
Thank you. All right, next question.
Yeah, hi, my name's Suzanne. I'm with a program called PACER in Calgary. And so I have a question for you. I've worked a long time in a nonprofit community service in downtown Calgary. So I'm very interested in how, as a community, you see research coming in, working with you, or I guess another way of asking that is, do you think you're the experts who can actually tell each other what it is that researchers need to know and then share that?
Yeah, that's, like, I never really accept the title expert, but, we're just experienced. And by that, I think we have a general argument about, what's going on. We might not agree on things, but, we can agree to disagree too. So.
One of my thoughts was, which you just brought up, thank you, was the issue of mental health. I work with a lot of teams that do peer-to-peer research, and we collect very interesting story that turns into data, that turns into information that's very helpful. Do you think in your community that is something that is worth sharing?
Oh, yes. I mean, anything's worth sharing. I mean, I don't care if it even looks half crazy, but I mean, that's just the way you find out about things. You gotta open the door.
Right.
I think a good example of that, I mean, there are always, whenever we do a joint meeting with the community advisory group, I ask for updates. And when I hear themes popping up over and over and over again about an unmet need and stories that are going on, then we start to look at, do we have pilot data? Do we have something? Do we have some information we can go on to build the case to explore this further? So recently we've had somebody bring it up several times, and we are working on it. One of our grad students is working on it this summer, looking at what are the unmet needs for people who use methamphetamines. And it's just something that, with the advent of the opioid issues that we're dealing with right now, we've it's not that we've dropped the ball, but it's taken a back burner. So that's an example of, they're more than happy to share the story of what's going on.
Right. See, I consider lived experience expert experience. So Keith and Jerry, I consider you both experts. Thank you.
Thanks very much. There was a question up here. Okay, yes.
I think I have two questions. The first is, if you could just describe a typical day for you guys. I find this is just so interesting. I also find, just listening to you, this seems like such an innovative program or a way of operating. And I'm just wondering how that's developed in terms of because we're sort of a research-based conference here, but I'm interested to know how this has kind of developed over the years to come to where you are now.
Okay, so the first question, typical day.
There, anyways, typical day for me would be, if I had to go on pure outreach, I basically get up at 9 o'clock in the morning. That's my my time since I'm getting old. But, I usually go for, I'm on methadone, so I usually go for a walk to the clinic and get that done first thing in the morning. And I've been on methadone for 21 years, and on a very high dose, and, it's done me miracles, but, not everybody's into that. But then I would probably try to get a hold of Chanel or something. If there was something like a meeting on a Tuesday, we'll go to that, gorge out and talk about what we have to tackle for that event for that 2 weeks, and then schedule stuff. But my, a typical day, I really could never pin down, if I rolled out of bed just the right way, it'd be a good day. If I didn't, it'd be a bad day. That's about it.
Yeah, my typical day is pretty well the same way. You never know what's going to happen. Some mornings it's feast, some mornings it's famine, and you just live with it, right? That's all we can do.
Okay.
It's like, asking for a typical, it's like asking a family doctor what a typical day is. There's no such thing. The second question was how we got here. Whoa. Okay. Aware existed before I got started. I think the first time I connected with them was when I was doing my master's, and Marlis Taylor, the program director at, the manager at the Streetworks Harm Reduction Program, I had been doing some work as an outreach physician there, and I said, I want to do some research, and she said, you have to talk to these guys, and that's how I met them first, was when I was doing my master's. And it blew it wide open for me. And after that, I said, this is the way we need to do it, is we need to connect and we need to talk and we need to find ways to make it meaningful. So that developed over time. We got one grant from the foundation, the Royal Alex Hospital Foundation, to kickstart a network, Edmonton Inner City Health and Wellness, Edmonton Inner City Health Research and Education Network, or ICRN, and we got started with that. We decided, well, we may as well involve the community in a meaningful way, so we got them doing our logo for us. We had a contest, we had a celebration and an award for it. We started doing, we decided we'd do a needs assessment. We got them to help design that. So it was a quantitative study out of the emergency department about unmet needs for people who were showing up for care. That built some pilot data. We learned a few things about KT with another project I was on at the same time, about best practices and getting them involved. And then we sought and obtained based on needs assessment data, the funding to kickstart the Inner City Health and Wellness Program. Again, that came from the foundation. I can't thank them enough. And then I found some matched funding thanks to partners from Addiction Mental Health SCN, who are also in the room. They helped us obtain Alberta Innovates Prius funding to look at the ARCH team more rigorously from a health services research perspective. So all of that built over time. But as far as our relationship through that, it just, we were intent on meeting with the community at minimum quarterly in the early days. And then we got them more and more involved with hiring and staffing and so on. As our budget expanded and our scope and our capacity expanded, we got them involved with more and more things. For example, messaging. One of them traveled with me to Saskatoon all week last week for a data hackathon. So as we have capacity, we ensure that their capacity is raised as well. So I don't know, that's a Cole's notes. And for more information about how we developed as an ARCH team specifically within all of that, we have some of that on our website as well, for those of you who are more into service planning and co-design. Yeah.
Well, I was going to say, there's also, Streetworks got an award for a Hep C video they put out back in 2000. I'm not sure about the year 2010 or something, maybe farther back. And that probably started a lot of things too with Streetworks and, opening up doors.
Well, that's just the thing. Where did Aware get its start? Do you guys want to talk to Aware and how it's grown over the years?
I only been there for 3 years. I mean, I don't have the years Jerry has, but since I've been there, for me, it's like kind of like, I don't know, minority. And at least that's what I feel like sometimes. And it's not an easy ride, like to be accepted by the rest of the group.
Jerry, do you want to speak to how Aware got more and more into kind of these?
Yeah, well, see, we started it about 14 years ago, and we were just a small group. There's like 3 of us, and we're trying to advocate for better people now. Then as years grew along, we kept on getting bigger and bigger. We're up to about 15 now, 16. Ain't very many, but it's hard to get some addicts to come out and help other people, right? So as the years go along, we, like I say, we just keep on advocating for them, and finally we get into bigger to where we are, and it's pretty good now.
Yeah, and we are no longer, we might have been the first group to approach you from a research perspective,
Yes.
would you say?
Yes.
But we're not the only group anymore.
No.
So that's just something that the early capacity building, but now they get approached by more than one group, for sure.
A lot of
So,
them.
yeah, and I think you guys weigh each of the opportunities and determine if it's of
And we
benefit.
pretty well accept any group, right?
But I think they still review it just to see, is this something that we want to do? Is this where our heart is? So.
Like, it doesn't, we don't always accept everything, of course. I mean, some organizations, we don't find they're trying to do the right thing or don't feel like there's validation to go along with it.
Okay. Yes.
I would like to know what you think of the word patient and how you feel about being called a patient for 10, 15 years. If you can suggest a different term.
Although, to be fair, I think we typically don't always talk, we talk to you guys about community members more than patients, honestly. That's where we started, but you guys can speak to that.
As far as being called patient, well, I'd like to have patience to be a patient because, it's really, up to the people that are giving the service, how good a service they give you, and how honest they are about, or admirable they are about what they're doing. That really helps a lot.
In our group here, I don't feel like I'm a patient. Right? It's just the way they make me feel. Right? They make me feel welcome. That they're not professionals. You're not a doctor. You're not this. So I don't feel like a patient. They make me feel like a friend, right? And that's what I like.
Great answers. Yes. Other questions or comments? Yes.
In our community, we were recently dictated a safe consumption site location. And I know a lot of people are for it and they were eager to have it, but then when they were told where it was going to be, it got the community into an uproar. Do you have a set of recommendations that help choose a site that is compatible for using people as well as the community members that don't choose? I'd like to help resolve some of this in my community.
I wish Elaine Hishka were here to speak to this because she was very intimately involved with all of the AMSIS work.
Maybe
it-
I
it
can
kind
just
of-
get her information.
Yeah, I can. And it was part of her PhD work, just really going to bat, trying to understand what the community needs were. So it was very informed, very evidence-informed, and a ton of consultation work went into it for our 4 sites in our city. It has not gone without some backlash, as many of you well know from the media, but it was very much informed and adopted from a public health perspective is the right thing to do, but based on data. So that's, I wish you were here, but I can connect you. Do you guys want to speak about? No? She was just wondering about how, do you want to reframe it again for them?
I'll tell you specifically. So everyone that I know that works in this profession is eager to have that to make it safer for users and safer for community members so that needles aren't in locations that shouldn't be. And I recently got involved in a very personal conversation because my son and his wife just bought a condo, and now it was across from a restaurant, like it's right by where they park their car, and now it's going to be or supposed to be a safe consumption site. And my son is saying to me, I'm worried about my wife's safety because she comes home late at night from work. So I'm trying to help him and the community understand where the best places are and why that's an okay thing.
Well, best places, they probably don't get the best places. I mean, you know, there's a lot of stuff that goes into just getting a permit for something like that. I know that not all of them have been in really good spots. I've had people, like one time in Cromdale, I went down there with a friend of mine, Kelly, and we were making that poster with the little girl poking at the needle, that one years ago. Anyways, we're going down there, and there was a community action thing going on about the box. We didn't know about it, but we just ran out of there because there was 500 community people looking to lynch someone. And, and that can happen, but, you've got to go about trying to, inform people. I don't know what is a good way, but I know in person, you got to make sure all the safety factors are in there. But.
And yeah, the best place could be anywhere, right? Because wherever safe consumption is, it's the best place. Like, they're going to save lives there. And that. A lot of people don't think, well, they think that us addicts are going to go out and kill them or rape them or do something stupid to them, right? And it's their thinking of why they don't like it, right?
Yeah, which doesn't bear out in the evidence as well, incidentally. I mean, if you look at a lot of the SCS published evidence out there, I mean, it actually doesn't reduce or increase crime in an area or anything like that. So you can point them to that data. These guys are excellent neighbors. They're very aware of the perceptions, and they routinely do walkabouts to pick up discarded supplies and so on and so forth. And they're doing outreach and they're doing PR to show people that, I mean, they're giving back, and they want a safe community as well. So I think they're aware, and there's other chapters, I don't know where you are, but they may have, your local chapter may have some ideas on how to improve those relations.
Great question. Thanks. Other questions?
Just so you know, we're able to take about 2 more questions, then we'll have to wrap
Okay,
up.
thanks.
Sorry for the second question.
Third, actually. But I mean, who's counting?
So I see that this is really a team model approach, like just you guys have different disciplines working in relation with one another. So I'm curious I guess I'm following up on my second question, which was like in terms of a research perspective, how did this come about? Was this sort of a vision that you thought, oh, hey, this is a great idea, why don't we do this? Or was it, we better do a needs assessment and see what's going on here and see what's needed? Like I'm still curious of, that 15-year process of where you are now.
Well, for me, it has been a vision for the past 30 years. I wanted to have some kind of cleanup on dangerous goods, and, like, I had a vision as far as having bikes with electric bikes with, disposal containers, needles and stuff like that going around, a low cost thing, something that the city wouldn't even have to worry about. And, instead they just pick up garbage, but, you could do both. But, I mean, that would be my dream to see in the year 25, something that is like really full of nothing but love and compassion.
Now, when I started this, it was a very small group and that, and where we grow to where we are now, I didn't think that we'd be doing that much help. And it sure shocked me because like a lot of people need help. And that's what we do and that's what we like to do.
I don't think we have specific ideas, but we have one great big goal, which is to improve relationships and improve health services, I mean, from my perspective. And so within that, I mean, you don't fix that in a day. It's a very complex system. There's many, many levers and many, many interventions that need to be taken into account. And so you get there again in baby steps. So the overarching goal hasn't changed. There's always room for improvement and enhancement of service. But then they have these fantastic ideas along the way on how to achieve that, if that makes sense.
Great. I think we have time for one more question, if there is.
Thank you. I'll talk slowly because I know my accent is a problem.
What?
I was just thinking about the question that the lady over there asked about concerns in the community of safe injection sites, and to me that's like a not in my backyard issue and is also really stigmatizing people and dehumanizing people. So I'm curious from Jerry and Keith if they came across that face to face, what they would try to do to convince someone what they're not a threat to the community, because I just see 2 great guys who have challenges, and I'm not thinking, oh no, I'm scared to be near you at night or whatever, but a lot of people in the community think that.
The way I figure the safe consumption site, where it should be located, is probably where most addicts are located, in your backyard, or in their backyards, right? And people don't realize that they have that, so that's why they're mostly against it, right?
If someone confronted you, what would you tell them? What would you tell my son?
Tell them it's a safer thing to do, like I said earlier. How many people died at a safe consumption site and how many people die on the streets?
Yeah,
And you don't want them dying on your streets, you want them to be living. So like, if you want them to die on your streets, don't get the safe consumption site.
We're saving lives. I mean, that's what I would tell them. And I try to give them a little history on my history to explain the situation. And safe sites, or safe consumption sites, there's always going to be hit and miss on that. And when, you have a real bad spot, it's generally someone's a little bit over exhilarated about, they have a picture, like a bad picture of stuff happening. But, you know, people that are putting these sites up, they have kids, they got worries and concerns too, but they're right on the front line. They're gonna take the first blow before anybody out there gets it. And they look after the neighbor around there too. You know, we can't do a perfect job, but somewhat a good job.
I don't know if I should put in a last word, but you mentioned, was it you who mentioned Rob?
Yeah.
So we have some peer support workers who work with the ARCH team, helping with patient care, but so we also had one of our peer support workers go around talking about, we had a harm reduction roving cart unit by unit rounds, and he went around with our nurse educator, and you talked about sharing your personal story, and often that's what it takes to totally turn people around. Like, oh, like there's a human face to this, and it's worth it. So sharing personal stories, I would agree. We have seen it in action and how it really changes the culture of a place.
And of all the addicts I've ever helped out, none of them ever threatened me or did anything to harm me or nothing. None of them.
Yeah, they're people, they need help, and, you know, like, we're willing to give them the help, that's all.
Thank you so much. What a great way to end, what a powerful way to start this last day of the conference. So let's start by thanking Jerry, Keith, and Ginetta for their presentations. So I think what you've seen is the experience, the importance of relationships, the importance of nothing about us without us, and you've seen the examples of the courage and the service that goes on. And so again, this is you know, a great way to start the day. This is the last time that we're together as a big group for the rest of the conference. So on behalf of the Alberta Sport Unit, I want to thank everybody who's come together for this, you know, the fourth time, another year successful conference. Be sure to take advantage of the many workshops that are available for the rest of the day. And we do hope to see everyone again next year. So our next item on the agenda is a coffee break, which is going to go until 10:45. I got that correct. And then be sure to join us for lunch, where the announcement of the best poster will happen as well. Enjoy the rest of your morning. Thanks, everyone.